The next important point is staging of CA larynx. So why we go for staging? What are the uses? You know that for any malignancy or the carcinoma of any body part, there are various treatment options. It can be either a surgery or it can be a radiotherapy, a chemotherapy or a combination of all these. By doing a staging, it gives a choice of correct treatment option, and second, the overall survival of the patient can be predicted, and also it provides a conformity for the clinicians and thereby helping or comparing the efficacy of each treatment options. And also this is an internationally accepted system, so the ongoing investigations on human cancer, this staging is very helpful. So in CA larynx, the accepted one is TNM staging, that is on the extent of primary, the nodal and the distal metastasis. So this is contributed from both sides of Atlantic, that is from European Union there is an UICC, International Union of Against Cancer, UICC staging system, and for America it is an American joint AJCC. In my institution we are following the AJCC staging system, and that I am going to explain that. And for T is extent of primary, okay, that is the primary tumor. For CA larynx, for this T staging, it is not the bulk or the size of primary tumor, but it is the extent of primary tumor or extent of subsite. I already explained there are so many supraglottis, glottis and subglottis, and there are subsites for each one. I explained that along with the spread of CA larynx, and it is the extent to these subsites that is determining the T staging. Okay, and it is not the size or the bulk of primary. And here the fixity of the vocal cord is very important. So you should be very careful in finding out the fixity of vocal cord. Fixity of vocal cord present or not, it plays an important role in T staging. Okay, and for N it is the presence or absence of the nodal metastasis, and also the extent of node, lymph node. Okay, lymph nodal metastasis. And M is presence or absence of distal metastasis, whether distal metastasis present or not, that is determine the T. So the primary tumor, the nodal metastasis and also distal metastasis is detected. T staging is not exclusively by the clinical evaluation, but after imageology comes the T staging. That means this TNM is a combined evaluation of clinical as well as radiological data. And also there are G, R, L and V, and this also help in the predicting the overall survival and prognosis of the patient. What are they? G is histopathological grading, histopathological grade of this tumor. R is recurrent or residual lesion. L is lymph vessel invasion. Okay, lymph vessel invasion. And V is venous. So for an internationally accepted classification, we can go with the TNM. But this G, R and L and V also help in predicting the overall prognosis or the overall survival of the patient. So it is the primary tumor, nodal metastasis, distal metastasis is combined by clinical as well as radiological evaluation and histopathological grading, residual lesions, lymph vessel invasion and venous invasion. Okay. The T staging for supraglottis, glottis and subglottis is different. But three things, Tx, Tis and T0 are same for all subsets. Tx means the primary tumor cannot be assessed, and the Tis carcinoma in situ, and T0 there is no evidence of primary. So primary tumor cannot be assessed Tx, Tis is carcinoma in situ, and T0 there is no evidence of primary tumor. And for supraglottis, T1 and T2, the vocal cords are with the normal mobility. Okay, normal mobility. Right? So T1 involving only one subsite with a normal vocal cord mobility. And T2 again vocal cord mobility is normal, but it involves either more than one adjacent subsite of supraglottis and glottis. So a glotto-supraglottic malignancy with a normal vocal cord mobility will be considered as a T2 lesion. Okay. Either more than one adjacent subsite within the supraglottis or glottis, or outside the supraglottis. What are they? Base of tongue, vallecula, and medial wall of piriform sinus. Okay. Either within the supraglottis, more than one adjacent subsite, or to the glottis, or outside the supraglottis, that is the example, base of tongue, vallecula or medial wall of piriform sinus with the normal vocal cord mobility is T2. T3 and T4, it is with the vocal cord fixity. For T3, it is tumor limited to larynx with the vocal cord fixation. Tumor limited to larynx with the vocal cord fixity is T2, or invading any one of the following structures. They are the postcricoid area or spaces. What are the two spaces? Pre-epiglottic and paraglottic space, and or inner cortex of thyroid cartilage. Thyroid cartilage inner cortex involvement is T3, but outer cortex involvement is T4A. That you have to remember. Okay. So for T3, it is either tumor limited to the larynx with the vocal cord fixity, or involvement of postcricoid area, spaces of larynx, that is the pre-epiglottic and paraglottic, or inner cortex of thyroid cartilage with the vocal cord fixity is T3. T4 is again divided into T4A and T4B. T4A is moderately advanced and T4B is very advanced carcinoma supraglottis. So T4A is invading through the outer cortex of thyroid cartilage. Inner cortex I already told it is T3, and T4A is outer cortex of thyroid cartilage and or invading tissues beyond larynx. What are the structures? Example, can be a trachea, or it can be soft tissues of the neck including the deep extrinsic muscles of the tongue, or it can be strap muscles of the neck or the thyroid gland or esophagus. Okay. So, outer cortex of thyroid cartilage and structures beyond the larynx like trachea, or soft tissues of the neck including the deep extrinsic muscles of the tongue or strap muscles of neck, thyroid cartilage and esophagus. And T4B is very advanced local disease like tumor invading the prevertebral space, then encasing the carotid artery, or invading the mediastinal structures. Okay. Mediastinal structures. So this is T1 and T2 with the normal vocal cord mobility. There is no fixity, and vocal cord fixity becomes 3 and 4. So this is T1, T2, T3, T4, A and B of supraglottis. What about glottis? T staging of glottis. T1, again there is T1, T2, T3 and T4 for glottis also. So T1 is limited to the vocal cord, true vocal cords with the normal vocal cord fixity. Okay, that is T1. T1 is again divided into A and B. T1A is limited to, so if you draw two vocal cords, T1A is limited to one vocal cord. The extent can be either it can go to the anterior commissure or to the posterior commissure or the entire length, but it should be limited to one cord with a normal mobility. And T2B is involving both vocal cord but with a normal vocal cord mobility. T1 is with a normal vocal cord mobility, T2 is impaired vocal cord mobility. Okay, that is this is normal vocal cord mobility. T2 is impaired vocal cord mobility or restricted mobility, and with either to the involvement of supraglottis or to the subglottis, and also this and or bar or is also coming in T2. So glottic T2 is involvement of the supraglottis and or subglottis and or impaired vocal cord mobility. Okay, so impaired vocal cord mobility, involvement of the supraglottis or involvement of the subglottis is T2. T3 glottis is similar to T3 of supraglottis. Here also the tumor limited to the larynx with the vocal cord fixity, or postcricoid area is not coming there, or either tumor limited to the larynx with the vocal cord fixity, as I already told, with the supraglottic T1, or there is involvement of the preepiglottic space, paraglottic space or inner cortex of thyroid cartilage. Okay, so either tumor limited to the larynx with the vocal cord fixity and or involvement of preepiglottic and paraglottic space, and also inner cortex of thyroid cartilage, as we have already seen in a T3 of supraglottis. The T4 glottis and T4 supraglottis are similar. T4 glottis again divided T4A and T4B, similar to that of T4 of supraglottis, moderately advanced, involving the outer cortex of thyroid cartilage beyond the larynx, structures like trachea or the neck muscles, including the deep extrinsic muscles of tongue or the strap muscles of neck or esophagus and also thyroid gland. And T4B is very advanced cancer involving the ensheathing of the carotid artery, prevertebral space and also mediastinal structures. So that is similar to that of T4 supraglottis, as I have already told that. So that is T staging of glottis. For T1 limited to the vocal cord with normal vocal cord mobility, and again to A and B. T2 impaired mobility and involvement either to the supraglottis and or subglottis and or impaired mobility. T3 and T4 almost similar to that of T staging of supraglottis. What about subglottis? So I am changing this glottis to subglottis. Okay, so subglottis, and for all this, for supraglottis, glottis and subglottis, this T3 and T4 are the same. Okay, but for subglottis, T1 is tumor limited to subglottis rather than to vocal cord. It is for subglottis, it is tumor limited to the subglottis, and there is no T1 A and B. For subglottis, T1 limited to subglottis, and for T2, this T2 subglottis is from the subglottis, it is extending to the glottis with a normal or impaired mobility. Okay, so T2 subglottis T2 is extending to glottis plus normal or impaired mobility of the vocal cords. Okay, that is T2. That means it is extending into the glottis with a normal or impaired mobility. And T2, T3 is the same. That is tumor limited to the larynx with the vocal cord fixity or involving structures like a preepiglottic and paraglottic space or inner cortex of thyroid cartilage. And for subglottis, it is T4A is moderately advanced and T4B is very advanced tumor, similar to that of all the other two subsites. So this is the T staging of subglottis. The N staging is depending upon the presence of lymph node metastasis, depending on the ipsilateral or contralateral. Ipsilateral means on the same side, contralateral means on the opposite side, and the midline lymph nodes are taken as ipsilateral lymph nodes. Then the ipsilateral or contralateral, single or multiple, and also the size. The 3 cm and 6 cm are taken as standard sizes, less than 3 and more than 6. Okay, so the number, then ipsilateral or contralateral, then the size, and also in recent textbooks divide them into a clinical nodal status and a pathological nodal status, PN and CN. Okay, so this clinical nodal status is depending upon the physical examination finding, then imaging, mainly radiology, and fine needle aspiration of the lymph node. And this pathological status is depending upon after histopathological examination of the lymph node after doing an excision biopsy. So that is the difference in the recent advance in case of end staging, and they are mostly they are the same in both clinical and pathological. And the important factor again, other than what I told was ipsilateral or contralateral, the size and also the number, it is ENE. What is that? It is an extranodal extension. Okay, presence or absence of extranodal extension. And in extranodal extension is determined by physical as well as radiological evidence of four things. One is presence of skin infiltration, skin pinchable or not over the lymph node. Then two, adjacent muscular infiltration, that we can see clinically, we can examine by the mobility, and also it should be supported by radiological findings. And the third is infiltration to adjacent structures, and fourth is neural invasion, that is to the cranial nerve or to the sympathetic trunk or to the brachial plexus or to the phrenic nerve. So extranodal extension as evidenced by either skin infiltration or muscle infiltration or invasion into the adjacent structures or into the nerve structure, that is the cranial nerve or the sympathetic trunk or the phrenic nerve or to the brachial plexus. Okay, so NX and N0 is same for both. NX is regional lymph node, cannot be assessed, and N0 is no regional lymph node involvement. Okay, N1 is the same in both, is a single ipsilateral lymph node, less than or equal to 3 cm and no extranodal extension, right? And if there is single ipsilateral lymph node of less than 3 cm and if there is extranodal extension, it is taken as N2A in pathological nodal status. Okay, so NX, N0 and N1 are same in both this. If there is an extranodal extension, then it becomes an N2A. And N2A in clinical is single ipsilateral of more than 3 cm but less than 6 cm with no extranodal extension. B, multiple ipsilateral, none more than 6 cm. All the nodes should be less than 6 cm in size and there should not be any extranodal extension. C is bilateral or contralateral, either contralateral or bilateral, and it should be, all should be less than 6 cm with no extranodal extension. This N3A is single ipsilateral more than 6 cm, but ENE should be negative. The pathological staging, N3A is single ipsilateral more than 6 cm, ENE negative become N3A in clinical, but if this extranodal extension is present, it become N3A in case of pathological nodal status, and any node with clinically overt extranodal extension of any size and any node, that become N3B in case of clinical nodal status. So this is the N staging. And what about M staging? M staging we have MX, M0 and M1. MX, the distant metastasis cannot be assessed. M0, there is no distant metastasis. And then M1, presence of distant metastasis. And in case of CA larynx, it is the most common site of distant metastasis is lungs, and less common there can be the bone and also the liver, hepatic and bone in metastasis, and the mediastinal lymph node if involved, it becomes an distant metastasis. Okay, so the most commonest site is lungs. There can also chance of bone and liver, and also if there is involvement of mediastinal nodes, it become a distant metastasis. Okay, so MX, M0 and M1. So that is the TNM staging, and with this again we can divide CA larynx into different stages depending upon the status of T, N and M. The disease can be staged from stage 0 to stage 4. Stage 4 is again divided into stage 4 A, B and C. Okay, so that is disease staging. The other one is for primary, nodal and metastasis. Depending upon the T, N and M, the disease is staged to stage 0 to stage 4. In stage 0, the T status is T in situ, carcinoma in situ with N0 and M0. Okay, and stage 1 and 2 is again EC, because there also the N status will be N0, M0 with the stage T1 and T2, T1 and T2, right? So that is a bit easy to remember, right? So the so the T and for stage 3, both N0 as well as N1 comes, but again M is 0, right? So what about T3, N0 is stage 3, but along with that if there is N1, T3, N1 is also stage 3, and also T1 and T2 if there is N1, it become stage 3. Okay, so N0 and N1 comes in stage 3, and what about stage 4? Stage 4 is again divided into 4A, 4B and 4C. So stage 4A. M status is always 0. No distant metastasis in stage 4A also. But the T status, we have written all except T4A. So the I'll write in red only. So the T is again T4A, and along with T4A the N should be N0. That is stage 4A. And T1, T2, T3. What is the status? So that should be N1 is already given along with stage 3. So here it should be N2. Isn't it? So T1, T2 and T3 with N2 should be stage 4A, and here it should be M0, and T4A with N1 and N2 is taken as stage 4A. It's very easy. You can compare it. So T4A, N0, N1 and N2 is stage 4A. N2 with T1, 2 and 3 is again stage 4A. 4B. Again the distant metastasis should be 0, and here stage T4B. So N0, N1, N2 and also N3 will come, that is T4B plus any N. Okay, is stage 4B, but here it should be M0 only. Okay, and what about other T's? T1, T2, T3 and T4, A and B. So any T with N3. Okay, again stage 4B. And what about stage 4C? There should be distant metastasis. So along with M1, any T and any N is stage 4C. So you should be thorough with this because the treatment plan comes with a disease stage.